I'm Zhou Jiegang from Nanjing Medical University. Cardiac resynchronization therapy is an effective therapy for heart failure with left bundle branch block. Traditional method is by the ventricular pacing. And as we know, left bundle branch pacing has been emerged as a novel modality uh, for an alternative CRT strategy for heart failure uh, due to its the stable pacing parameters and favorable left ventricular electrical and mechanical resynchrony. More and more studies show that LVB pacing can effectively improve cardiac function and prognosis by correcting left bundle branch block. However, in some patients, LVB pacing cannot successfully capture left bundle. Only LV septal pacing can be achieved. So, whether LVSP can also be used as a resynchrony therapy for heart failure remains unclear. And I will review some studies about the effect of LV septal pacing for resynchronization therapy. This is a prospective multi-center observational study from America. It compared the clinical outcomes of LV pacing versus LV septal pacing and biventricular pacing. Totally 415 patients were included. Among them, 141 were LV pacing, 31 was LV septal pacing, and 243 were biventricular pacing. The primary composite outcome was freedom from heart failure, hospitalization, or mortality. So in this study, 76% were in LVB pacing, and 48% in LV septal pacing, 43 patients in biventricular pacing. So LV pacing is superior to LV septal pacing and biventricular pacing regarding in reducing the heart failure hospitalization and all-cause mortality. But no difference was observed between the LV septal pacing and the biventricular pacing. Our study also investigate the long-term outcome between the three different CRT strategies of LV pacing, LV septal pacing, and biventricular pacing. 259 patients were screened and followed up about 28 months. The results showed that, as this shown in this figure, LV pacing significantly reduced the risk of primary outcome. The primary outcome includes the all-cause mortality and heart failure hospitalization. So in LV pacing, the primary outcome is 7.4%. In biventricular pacing is 41% and 47% in LV septal pacing. So LV septal pacing and biventricular pacing were similar. And we also adjusted the risk factors. We can find the all-cause mortality was significantly higher in LV septal pacing than biventricular pacing. This study from the Mayo Clinic, and they want to assess the echocardiographic and clinical outcomes of LV pacing, LV septal pacing, and deep septal pacing. As we know, if we want to puncture the interventricular septal, sometimes we can't go to the left side, so the LV tip may be in the deep septal. So they included 91 patients, and 52 patients had LVB pacing, and 25 achieved LV septal pacing, and 14 were deep septal pacing. In this study, they showed that LV septal pacing had a comparable cardiac synchrony effect as LVB pacing. They can achieve similar improvement of LV ejection fraction, heart failure hospitalization, and overall survival. However, deep septal pacing had no significant effect on these parameters, including the clinical outcome. So this study give us information about the deep septal pacing is not the final the goal for the LVB pacing. So let's talk about the possible mechanisms of LV septal pacing served as a CRT mortality. So this study was to investigate the impact of LV septal pacing and LVB pacing versus biventricular pacing on the ventricular electrical synchrony and hemodynamic status in CRT patients. 35 patients were included, and the mean ejection fraction was 29%, and the QRS duration was 168 milliseconds. They found LV septal pacing provides the same LV synchrony and hemodynamic status as biventricular pacing, while LV pacing had a better effect than these two methods. This is another study to compare the electrical physiology and the hemodynamic effect between the LV septal pacing, biventricular pacing, and His-bound pacing. As we know, His-bound pacing is the most physiological pacing modality. And the results showed that LV septal pacing achieved a great reduction of QRS area compared to biventricular pacing. However, the increase in the LV DP/DT max was similar between the LV septal pacing and the biventricular pacing. So this study demonstrated that LV septal pacing can provide short-term or say the acute hemodynamic improvement and electrical synchrony, similarly with the biventricular pacing and His-bound pacing. So this study should indicate the LV septal pacing can serve as a valuable alternative for CRT. So this is a positive study for LV septal pacing using as a resynchronization therapy. So what's the true difference of LV pacing, LV septal pacing, and deep septal pacing? LVB pacing means the tip of pacing lead is located at subendocardium, and the key point is LV left bundle branch is successfully captured. So this is very important. The deep septal pacing means the tip of pacing lead is far from left endocardium and only local myocardium is captured, as shown in this figure. So it is far from the left subcraniocardium. However, LV septal pacing, even we have no evidence to confirm it captures the LVB, but the pacing lead is almost at subendocardium, so it might indirect capture of left conduction system, even when we use the high output. So sometimes LV septal pacing can indirect capture left bundle. So the question for us is whether LV septal pacing can be used as a resynchrony therapy for heart failure. In the real-world practice, LVB capture was not achieved successfully even in a typical left bundle branch patient, especially in IVCD patient. As we know, IVCD means it is not a typical LVB or not typical right bundle branch block. So how to optimize the synchrony for LV septal pacing? With the LV septal pacing combining with apical LV pacing can enhance the electrical resynchrony and improve clinical outcome. So how to face this diploma of LV septal pacing in the clinic? In 2021, Mark Foster proposed a concept of lot CRT. And in his study, lot CRT can achieve bad electrical resynchrony. They use the three-dimension anatomy mapping system shows electrical resynchrony can be achieved. And they also found the lot CRT can achieve the hemodynamic effect. Also can improve the LV ejection fraction. So how to apply the lot CRT in our clinical practice? I mean, when to consider lot CRT strategy. One scenario is LVB block can be corrected by LV pacing. I mean, we just achieve the LV septal pacing. At this condition, maybe we can consider the lot CRT strategy. The second is IVCD. IVCD cannot be corrected by LVB pacing. So these two scenarios, we want to consider lot CRT for these patients. So next, I will briefly introduce our recent study, SPORT study. This study with collaboration with the Dr. Fai Xiaohan. So we two groups included the LV septal pacing patients add or combine with the left ventricular epicardial pacing, try to compare the effect of LV septal pacing with or without LV pacing. So just published Europace. So this is the flowchart, and finally we include 45 patients to our study. Among them, 25 patients were LV septal pacing alone, and 20 patients received LV septal pacing combined with LV pacing. So this figure shows the change of QS duration, and we can find the QS duration significantly decreased in both groups, but in LV septal pacing plus LV pacing group can achieve more QS duration decrease. And we also measure the acute hemodynamic response use DPDT during procedure, and it can from the left panel we can find LV septal patient plus LV patient can achieve more improvement of DPDT max. This figure shows the improvement of LV ejection fraction and NT-proBNP and New York Heart Association classification. So the key outcome I want to share with you the clinical outcome. We also use the composite clinical outcome, including the all-cause mortality, heart failure, hospitalization, and ventricular tachyarrhythmia. So from this figure, we can find the composite clinical outcome were totally significantly different between two groups. Similarly, heart failure hospitalization also have a significant difference. But all-cause mortality and ventricular tachyarrhythmia, no difference between two groups. So this SPORT study show us if we can't achieve successful LVP pacing, or sometimes we cannot confirm the successful capture of left bundle, but we found the QRS duration has a bit decrease. At this scenario, we choose the LV septal pacing alone, or we decided to add epicardial LV pacing lead. So from this study, we found the LV septal pacing with LV apical pacing can achieve the better electrical resynchrony and hemodynamic response, also the clinical outcome. So in summary, LV pacing is an effective resynchrony therapy modality. LV pacing can achieve great benefits compared to the traditional biventricular pacing. And also, LV septal pacing with epicardial LV pacing can improve acute electrical resynchrony and hemodynamic effect and clinical outcome compared to LV septal pacing alone. Large-scale trials are warranted to further validate these findings. Okay, thank you for your attention.